I would say that the book, the excerpts of such those areas are very good, and the suggestions that came up are very, very apt. And I think it's good to read. Everybody should grab one and read. Thank you very much.
Great. Thank you
Over.
so much, Doctor. Thank you so much, Dr. Yeboah. Kingsley, I see your hand up. I'll come to you in a moment. But before, let me just read through something that Maxwell has dropped in the chat. So Maxwell starts off by saying, first off, many congratulations to you, Norman, for putting together this book. Well done. And then he goes on to say that I guess he means bystander activation of emergency medical services is something that needs to improve. Public education on what to do in an emergency situation needs improvement. He goes on to write, the National Ambulance Service is piloting an interface of its pre-hospital information management system, PIMS, with hospitals in Accra to share clinical services availability, radiological services availability, laboratory services availability, COVID beds availability, oxygen versus no oxygen, and all this will ensure that patients are not sent only to known hospitals like Konoche and Kolebu, but to wherever the nearest hospital most appropriate where some of these services can be provided. Very, very spot on, Max. Thank you so much for the effort and for dropping it into the chat. Was trying to connect, but it seems the connection was not too strong from your end. Thank you so much for sharing these insights with us. Kingsley, if you'd like to unmute and make your point.
All right, Mr. Frimpong, thank you very much, and it's a pleasure seeing you and the great job that you're doing facilitating this book launch. And Norman, kudos to you, and obviously also to your wife. Just as OT made mention of, I've also known Norman to be somebody that always likes to express divergent opinion from our days back in Preventive College. So I'm so glad to see that, you know, as part of your career, you are sharing your experience with the world and making sure that, you know, we can add on to the quest to improve healthcare delivery in Ghana. I do have a quick question. And, you know, one of the things that lately I would say from my visits to Ghana, and I've seen it with so many of my family members, all that you hear is this person was taken ill and it was an acute situation. They have to be hospitalized. They needed a surgery, maybe they need maybe like a bypass. And it leads me to ask the question of what is the state of preventive care in Ghana? You know, when it comes to measures to help prevent these healthcare problems getting so acute to where it might require hospitalization, or it might even require like intensive care. And I bet you that is where it becomes even more expensive. If, let's say, you know, you have a stroke, or let's say somebody goes into a coma, and most often than not, that is where it also requires a specialist. So I've always been grappling with that thought of, you know, what is the assessment? For those of you that are in the medical field, what is your assessment of preventive medical care in Ghana to where things do not get so acute to where we would need to get people hospitalized or even need like special care that requires so much cost, which obviously comes to add on to the financial constraints. So I wanted to see if, as part of the book, it addresses that question of preventive care, or if any of the experts on the panel can share any thoughts, like maybe things that we can help educate our families on, or even from a policy standpoint, you know, people in the ministries or people in government, to where we can help, you know, get things contained at the lower level before they get so up high and make things very difficult. So if I could get a good assessment of preventive care medicine in Ghana, I think that will be very helpful to me. And thank you for the opportunity to
Thank you very much, Kingsley. Thank you. Interesting question. I don't know whether, Norman, you want to react to that, or Dr. Yeboah, and then I come to a question that Sam has in the chat as well.
All right. Thanks, Fred. I want to thank everyone once again for joining. Maxwell, it's good to have you on. I noted your comments, and yeah, congratulations for the work you are doing as well. I did talk about resuscitation and, you know, training in resuscitation in the book as well when I talk about the emergency systems. And I did mention that one of the things I had to do before I started getting on the schedule, the rota working here, was to do a UK Advanced Life Support course. And I do realize that resuscitation and capabilities and training is not something that we are doing a lot in Ghana. It's improving, but there's still a lot to be done. When I was last in Ghana, I actually gave free teaching on resuscitation to a health facility in Ghana. And in this book, I've mentioned, and Maxwell, since you are at the top, I've mentioned that Ghana needs to have a resuscitation council. So I hope that idea will be taken on board. It will be really good, and it will really help with the things you've mentioned. And Kingsley, it's good to hear from you. Thank you also for joining. Preventive care, and I do agree with all your sentiments. So on the public health side of the book, I talk about a double burden of disease in Ghana, and that is something you find in most developing countries. On the one hand, we have a lot of infectious diseases, but on the other hand, the NCDs, or the cardiovascular diseases, you know, are also on the rise. Hypertension, for instance, if you look at research that has been done, depending on which research you quote, is about 50% in Ghana prevalence, very high. In certain cities, it's even higher. So preventive care is crucial. We definitely have to look at that. And in this book, I also talk about community care as part of the strategies to address the no-birth syndrome. Thank you.
Great, thanks, Norman. So I'd like to go straight into the chat. There's a question from Sam. So Sam writes, quick question on the issue of weaning our hospitals and health systems off central government financing, if that's the point. If that's the point Norman makes in the book, isn't that akin to privatization? My understanding of the challenges facing the UK NHS at present is that the marketized approach promoted by the Blair government has compounded rather than helped with efficiency in NHS. With this in mind, two questions. Won't the same problems emerge in the Ghana situation? And how do we ensure that the poorest do not face further challenges with healthcare access in a system that's privatization in all but name? Norman, would you want to react to this?
Yes, definitely. Thanks, Sam, for joining. I do share the sentiments, and it is true. So what I've actually proposed in the book is actually a private-public hybrid system. And I was looking at the data again, in terms of private involvement in the work of NHIS in Ghana is about 17% or so. And then in the UK, it's about 11%. So there is definitely some private involvement, but what I actually highlight is that at the moment, a lot of patients also go to these private facilities using the NHS card or the the NHIS card, sorry, in Ghana. So if these facilities can't provide free healthcare to these people, then even though it's a private facility providing it, but to the customer, it's still free healthcare. In terms of the government facilities, basically what I've said is that these government facilities should get regular on-time NHIS reimbursements monthly, and that they should use it to run their facilities. Of course, governments are mentioning again in the book that government can continue to support facilities who need it, and especially in deprived areas. I feel that finance is the elephant in the room, health financing. And I can see challenges with government finance and everything without finding innovative ways to keep these facilities working.
Great, thanks, Norman. And Maxwell writes back. Maxwell writes again saying, congratulations once again, Dr. Norman. You are spot on regarding the Resuscitation Council for Ghana. It's long overdue. And he continues, I think the Emergency Medicine Society of Ghana, Pediatric Society, and the Anesthesia Society should lead the discussion with the Ministry of Health. Dr. Barnabas can certainly facilitate this. So, Doc, we kind of drawn you into it already, and we believe it is something that you will gladly take up. And Sam comes back to say thanks and kudos, Norman. In case Sam doesn't ring a bell, this is Senior Expo. Oh, it's our very own Expo. Oh, Prof, good evening to you. It's our very own Expo from Preventive College. And he says, I look forward to reading this important addition to the existing knowledge on health financing and access in Ghana. And Norman, knowing Expo, I know he probably will send you a copy of the book back with some comments in the columns. Great to have you join us, Prof. Great to have you. Doc, I'll come back to you. I see your hand up, Dr. Yeboah.
Yeah, all right. Thank you very much, Fred. I wanted to comment on Kingsley's first question on the state of preventive care in Ghana. Yes, I think it's a very good question and a very good call as far as preventive healthcare is concerned. We've done a number of things, I mean, as a health sector to ensure that preventive healthcare is done at the right, the right sense of it. Unfortunately, funding again has always been a challenge when it comes to preventive healthcare. It looks like we are more centered on curative than preventive. So most of our budget allocations go into curative. But fast forward, for the last few years, let me say for the last, as of 2020, when we developed our national health policy, the policy direction now is centered or focused on prevention. So some of the priorities of the Ministry of Health now centered on preventive activities. So like Dr. Norman mentioned about NCDs that are emerging these days, is something we are putting a lot of efforts to ensure that we are able to manage the NCDs very well. So we have a policy, a national policy on NCD that has been approved by Cabinet, and we are in the process of implementation. And again, as part of the preventive strategy, we also came out with a health promotion division at the Ghana Health Service, which is supposed to be doing a lot of the preventive work. And of course, the Ministry of Health has also established a health promotion directorate that is also going to put more attention and focus on prevention. But nonetheless, the issue on the ground has to do with our various districts and institutional arrangement, where they have to let the communication, the health communication, the information and all that for people to know what to do and what not to do. One of the things we are doing, the chip system, bringing close to client healthcare service to everybody in Ghana. so that you can walk to the chief zone, to the chief's compound, and if you have any challenges, you talk to people. Apart from that, we are also working with the Ministry of Education in terms of school health, in terms of adolescent health services, and all that, so that our young people and our mothers and everybody is given the needed attention. And one of the concepts we are using is a life course approach. So we are making sure that every age group limit within the system is covered. So really, we are doing something, but it's not enough when it comes to preventive care because of funding issues. Most of the funding come from our development partner when it comes to preventive care. So, but now that we are pushing for Ghana to do something, and then the health policy, for instance, we have done a mapping and for every ministry and how they can include health in their planning, what we call the health in all policies. So we've looked at, for instance, Ministry of Energy, Ministry of Mines Ministry of Mines and Natural Resources, Ministry of Water and Sanitation, Ministry of Education. We've mapped up those preventive things that we should be doing at all the ministries and engaging them to channel more resources into that area. So that, because at the end of the day, the burden comes to the ministry, the health sector. But if we're able to prevent this right from the goal, look at the water situation, the Galamsey situation, it has an impact on our health. You understand? If you take sanitation, if the local government is not working properly, it affects health, cholera cases, typhoid, and all that. So really, we are partnering with the ministries so that we can prevent some of these cases. And then the palliative care. Yes, it's also one of the essential care packages. Kingsley was talking about that. So that if somebody gets stroke, how are we able to help the person rehabilitate, come back to life? So these are things that we, as a ministry, we are now trying to refocus in our universal health coverage roadmap. So I believe what we need now is the funding. The funding is the problem. Let me say that, yes.
So Doc, what I hear you say is money answereth all. So hopefully the suggestions that are coming from these discussions and the thoughts that Norman has shared in the book would help us craft this and open up the space. So I see in the chat, congratulations to you, Norman, from Charles Redu Opong. And in keeping to the spirit of respecting your time, I would like to give the last slot to Dr. Chris Opong. Doc, Chris, did you want to just unmute and make your point? And after that, I will have to come back and with the permission of the chairman, we'll wrap up the event for the day. So Chris, over to you.
All right, thank you very much, Fred. Congratulations, Dr. Norman, as well. I'm very proud of you. We've been having these discussions in writing, and I think that's going to benefit a lot more people. But it was going to be a question for Dr. Norman, but I think since time is up, I'll just have to add just a contribution.
Chris, please fire your question. Norman is going to have an opportunity of last
so
word. So
Norman, yeah, I wanted to ask a question. From my experiences from Africa, in the UK, in the US, the no-birth syndrome is almost everywhere, just that it's a bit exaggerated in our country. And for those of us on the ground, we don't see it ending anytime soon. So personally, I believe it's going to be a long-term solution. I don't see it being solved in the short term because we don't have resources. Our primary healthcare is very bad. And the solution currently at Confanoche that some of us had to come up with is that now we allow every patient to come in instead of just giving them the go-ahead. When there is a bed, we allow everybody to come. They come in queue. And at times it's so bad, some people die whilst waiting. The government, at times they put a lot of pressure on us, like, well, why are you turning patients away? Why are you doing this? But the reality is that no bed does not mean just a bed that you can get from anywhere. It's the human resource. How many doctors are on the ground? How many nurses are on the ground working? What oxygen how much oxygen do you have available? What equipment do you have available? So now we allow everybody to come in. The place is always full. Quality of care is always down, but the public likes it that way. That's what we've realized. So we are also helping them. But the reality of the matter is that when there's congestion, there's very poor care. The quality is that bad. And those of us from the ground, we don't see any solutions now. Well, not enough specialists, not enough, nurses on the ground in the emergency, even the doctors. So I see it as it being probably managed. I won't say so in the next 10 years. But what do you think about it, Dr. Norman? Do you think we can cut it shorter than maybe the next 10 years? Because I don't see the way forward. Knowing the situation on the ground, the human resource that we have as a country. Now we have terrible drain, especially with the nurses. And I don't see it being solved within a short time. What do you think, Dr. Norman? Thank you very much.
So Norman, I'll give the opportunity to respond to Chris's comment and also wrap up by telling us where we will find copies of the book. And then after you, I go back to Doc to formally close the event for us so we can respect everybody's time. So over to you, Norman.
Thank you, Chris. Thanks again for joining. And you are one of the people I have a lot of discussions with. I talk to you about a lot of things, so I'm sure you have a lot on my mind. And I do agree with you. In fact, if you read the introduction of my book, I talk about the fact that there are no quick fixes. And I believe that the issue is a systemic and structural, there are systemic and structural issues that need to be fixed, and that will take time. But there are things that can be done immediately, and there are things that will make changes. And so I've really talked about some of these things in the book. And for instance, things like what Dr. Osei talked about, which is about basically attitude. I do talk about that when I talk about patient empowerment, and also the fact that we, the clinicians, need to appreciate, and of course the managers, how much government loses or the NHIS loses if patient takes up, beds that are not warranted. So there are issues that I've talked about in terms of health financing. Some of the issues needs financing. There are management issues, which again I've talked about in terms of decentralizing and making sure that management is not too central. I also talked about emergency systems. And one of the things, for instance, we can do, which I have suggested in the book, for instance, in the UK, they do have a 4-hour period. Basically, you are not supposed to spend more than 4 hours in the emergency unit. And of course, they do have challenges meeting it, and most hospitals do not meet it, but it sets a tone and it kind of gives a certain direction. If Ghana, for instance, were to set a certain time that patients cannot be in the emergency department, there will be a push on clinicians to make sure that patients in the emergency department, for instance, are moved to the wards, or where they can be managed in the peripheral hospitals, they are moved there. So there are things that can be done immediately, and there are things that will take time. So I think that's what I would say, Chris.
Norman, where do we find copies of the book?
The book is on Amazon, and I think a link has been provided in the chats. Also, we are planning to get paper or printed copies in Ghana that will be available in certain areas. And obviously, we are hoping to also share copies with key people in key positions, and hope that will help. Thank you.
Okay, Norman, I've already warned you, and I'll repeat my warning. Don't send me a free copy. I'm paying for this. Doc, we want to come back to you as our chair for your final wrap-up words for us, so we can respect our participants' time. We are 11 minutes past 7 by my clock. So Dr. Yeboah, back to you to wrap us up.
All right. Thank you very much, Fred, for a good work well done. Let me say in my concluding remarks, I think clearly Dr. Norman has been able to explain the purpose of this book to us. He's been part of the Ghana's health system. He had a lot of experience on the ground, and he's been able to espouse this in the book to help us also understand how we can resolve our problems. And I think the book is worth reading. But the fundamental issue that we've all discussed, all the comments that came in suggest that the Nobel syndrome, it is not just one particular issue, it's a multifaceted problem. And we've all agreed that it is not just one thing, it's not just about no bed. There are other related factors, which has been clearly explained by our panelists. Dr. Lawrence articulated it very well. As human resource, it's a human resource problem, it's a skill issue, it's capacity problem, and all that. Dr. Aduma also made her submission to also suggest that we need to strengthen our telemedicine e-health because, I mean, these days we are now in the era of technology. And honestly, I know in the UK, the US, telemedicine is high on the in terms of implementation. And Ghana, we are doing something, but it's not well coordinated, it's not well harmonized. And I think that from Dr. Adume's suggestion, we need to be doing something more vigorous and faster. We also agree that leadership is also part of the problem. If we have good leadership and management systems and the structures are well designed, I believe, honestly, let me just make this point. When we went round the 7 hospitals and we got one of the biggest hospitals, I sat over 2 weeks when this issue came. The CEO doesn't know what happened on the ground. So like Dr. Lawrence said, we sit in our offices, we sit as directors or whatever, and we don't care what goes on the ground. But if you really go to the ground to see how the staff are working, the challenges they are going through, and we appreciate it, I believe we can solve it. And it is not possible that we should have no bed syndrome. If you come to Greater Accra, for instance, there are a number of hospitals where we can work together, or hospitals can work together. Dr. Aduma talked about the dashboard, where you ambulance service is hooked on it. All administrators or all hospitals are hooked on that dashboard. You can see clearly where there are beds, where there are no beds, where the skill set is there. For instance, if you go to regional hospitals, you should be able to know the kind of doctors, the specialists that are available. So if you're a district hospital, if you are the district hospital and a medical officer, if you want to refer, you look at the dashboard, you're able to tell this place, we have this specialist in place, there's no specialist on this case, so let me go here and all that. And it is electronically managed. You don't have any problem. So I think the book is very thought-provoking, and it gives us the room for us to continue to look for tangible and lasting solutions. So like our last speaker said, it is not possible to solve it now, but Dr. Norman believes that we can solve some of them now. And that is what we need to do. Those that we can look at long-term solutions. Let's put a plan in place and do that. And I think Ghana health system will be the best. So thank you very much, everyone, for joining us on this important launch. And I'm grateful for this opportunity to chair this function. So thank you, and God bless us all. Thank you very much. Over.
Thank you so much, Dr. Yeboah. We are so grateful that you accepted to join us today and to chair this event. We very much appreciate your insights and the words of wisdom you've shared with us. We're hoping that the book, based on the interaction and discussion it has already generated, will lead us to make some decisions that will improve the healthcare delivery system. So thank you so much once again, sir. We appreciate you. To our two panelists, Doctors Adoma and Osei Tutu, we are so grateful that you could make time to share your experiences with us as well. We are grateful. To all our other participants who made time to join us, we're so grateful, and we thank you that you could honor this invitation. A couple of messages from the chat and we wrap it up. From Senior John Nkrumah, he says, congratulations, Dr. Norman. Well done. From Eunice Kunedu Ade, it says, congratulations to you, Dr. Norman. I believe that the object of this book in terms of stimulating discussion and leading to action has already begun on this platform. Like Norman said, the book is available on Amazon, and arrangements are being made to get hard copies available as well. For me, as a non-medical person, what I leave this discussion with is that apparently when we say no bed, it's not as simple as that. It's not just about the physical beds. So maybe that is what you medical experts need to educate the public a lot more on, because sometimes we take it literally and go like, well, now I'm past their bed, so they're hospital way. But apparently it has implications on the number of staff available, the personnel available to take care of the patients and all. For me, the critical thing reviewing excerpts of the book was when the author says we are not looking for quick fixes, we're looking at solutions that are sustainable and can take us long-term, a long-term view to the whole challenge, and to be able to move the needle in the right direction. Kelvin Joshua says, congratulations, my dear brother, Dr. Norman. Keep up the good work. So at this stage, I would like to say thank you to you all, and a big congratulations to Norman and the missus who stood by you to put the book together. We look forward to reading and engaging further, and we look forward to having even more of such interactive conversations within smaller groups to bring up the change that we all want to see in the healthcare delivery system. Again, I'll end with the quote by Mahatma Gandhi, that health is the true wealth and not silver or gold. So take care of yourself out there, stay safe, and let's keep engaging. Thank you all for coming.
Thank you, Fred. Thank you, everyone.
Thank you.
Thank you, Director.
Thank you.
Just one last request. As many of you as are able to come on camera, if you could switch on your camera so we could take a quick picture. As many of you as are able to, if it is convenient for you to switch on your camera. Our IT support person wants to take a quick picture for Norman to make a memory of this event. Don't worry, just Ruth, just park for a minute and let's take
I'm
this
driving, so the
with
picture should be fast.
Okay, so someone will be quick. Ruth is driving. Ruth, please keep your eyes on the road. That's fine. Once we have your face in, we are okay. All right. So if you could say smiles, and then we can have it in. 1, 2, 3, cheese. Snuggles. Samuel, do we have enough? Thank you so much. Thank you all so very much.
Thank you very much.
Enjoy your evening. Enjoy the rest of the day wherever you are, and stay safe. Bye for now.
Thank you. Thank you.
Bye, everyone.
Oh.
I'm afraid I'm still here.
Be the chef.